Good afternoon, all. Might just wait for a few more people to come in, and then we'll get underway.
Good afternoon, everyone, and thank you for joining us. I can see we've got over 50 people on now, so we might kick off. It is 2 minutes after 12:30. On behalf of the HITH Society, thank you for joining us, and thank you to Dr. Michael Young for agreeing to speak today on a topic that has clearly piqued a lot of interest, and is an area that can be very complex, and Michael's going to try and break it down for us. For those of you who don't know Michael, Dr. Michael Young is a rural generalist who's been actively involved with HITH programs now for over a decade. Michael was instrumental in setting up Townsville Hospital HITH and is a long-standing and respected HITH clinician. Michael's co-founder of Hospital in Your Home and actively participates in Hospital in Your Home clinical matters, including providing medical governance for private clients of Hospital in Your Home. He has a passion for developing efficient and sustainable models of care that focus on improving patient outcomes, whilst providing value across the healthcare continuum. And also of note, Michael has been on the board of the HITH Society of Australasia since November 2019. If I can ask that you stay on mute during the session, and there'll be plenty of time at the end for Q&A, but you can also add questions to the chat or to the Q&A section if you would like to during the meeting as ideas come to your mind. Those of you who can, if you're going to ask a question, if we could have your camera on if possible, please. And after the meeting, we'd love to hear your feedback on the session and also any future webinar topics you'd like to hear from. So without any more, I'll hand over to Dr. Michael Young, who's going to take us through HITH Funding 101. Thanks, Michael.
Thank you very much, James, and thank you very much to everyone for their interest in this topic. I see that there's a vast array of people out there in the ether. Some of you will know a lot of what I'm going to talk about, but some of you might not. So I'll just flick over to my PowerPoint. Okay, so everyone can see that.
Yep, we've got you there, Michael. Thank you.
Excellent. Very good. Okay, so thank you very much for the opportunity to have this conversation today. This actually started with just some queries around how in general how hospitals are funded in Australia on a HITH chat group. So the purpose of my talk today is to basically demystify how the health system is funded in Australia in general principles. I'm not going to go into fine detail, but I think for us as providers of hospital in the home, oftentimes attached to hospitals, it's really important that we have a clear understanding of how the health system is funded in the locations that we work in, and then therefore transfer that across into how our HITH services are funded, and then ultimately how we can use that knowledge to build a better business case for how we can build a more sustainable funding mechanism going forward. Because from what we see, a lot of HITH services, are run on a very tight budget. And sometimes, you know, we're looking for more resource. We need to be a little bit more informed as to how we put up a case, a better business case to get more resource to provide better care. The Australian healthcare system, like all healthcare systems, is very complex. We have a number of different funding instruments. We've got a number of different authorities that are involved in healthcare funding. And obviously we've got a lot of acronyms and a lot of terms that are involved, all related to, and a lot of players involved in how the system is funded in our particular state, in our particular geographical location. So this is it in a nutshell. So if we have a look at this, I'm just going to go sort of right the way from left to right, and we'll talk about who's responsible for what aspect of funding care in Australia. And this is all levels of healthcare in Australia are encompassed in this flowchart. So basically we have the federal government or the Commonwealth government, which sits in Canberra and is responsible for funding the Medicare program. And Medicare and aged care are the two big programs that are 100% funded by the federal government. And from Medicare, then we have Medicare funding primary care, specialist outpatients, radiology, pathology, and PBS medications. So that's the main funding goal of what Medicare has been set up to fund. However, Medicare does actually have a part to play in funding some hospital care as well, because for those patients who are admitted to a private hospital, their private health fund will pay the hospital for the hospital charges, so the bed charges for every day. But it's actually Medicare that rebates the doctors for the care that's provided whilst the patient is admitted. So those are the contributors to who pays for a private hospital admission. And with that private hospital admission, there's oftentimes an out-gap payment that a patient has to make as well, because Medicare will only fund 85% of the cost of that doctor. So the patient will either wear a 15% gap, or alternatively, the health fund may have an agreement with that hospital to fund that gap. And that's the important thing when we're talking about private health insurance funds, is it is hospital dependent, it is organisation dependent. So every organisation holds a contract with a private health fund, and they're all different. So Cabrini's contract with Bupa, for example, is different to Marta's contract with Bupa, is different to St Vincent's contract with Bupa. They're all different and they're all negotiated individually. So that can add a level of complexity if you're running a private HITH around who pays, how much the health fund will pay and remunerate the hospital and the clinician as well. Then we go to the state government funded hospitals, which are, so the state government's responsibility under the National Health Reform Agreement is to pay for public hospitals, state-based public hospitals. But interestingly, the federal government also makes a payment to the state government to offset that cost. So it's normally around about 40% of the cost of the state government funded public hospitals have a contribution from the federal government as per the National Health Reform Agreement, which is I'll discuss in our next slide. So state governments will fund their hospitals through activity-based funding, which is where every individual admitted condition generates a certain amount of revenue, and every condition is different, and every condition has a rider on how much complexity is involved in that condition will reflect how much the hospital is remunerated to provide that care. And then we have our smaller hospitals that are block funded, that just get a certain quantum of funding every year to open their doors and provide care. And normally we find that those block funded hospitals are smaller rural hospitals or mental health hospitals, whereby they don't have enough volume of service to generate enough activity-based funding to actually provide, to cover the cost of opening the doors of that hospital every day. And finally, we have another funding source, which is patients that are self-funded. So not a huge component in the Australian healthcare system, but some patients don't hold private health insurance but wish to be admitted to a private hospital, so they'll pay their full out-of-pocket cost. But then we've also got other insurance companies like road traffic insurance, third-party insurance, and DVA that will all contribute to an admission either at a public hospital, a private hospital, or for outpatient level care. So it all comes back to the federal government when you look at it. The federal government pays, you know, for primary care, they pay a contribution to private hospital admissions, both for the admission, but also they do subsidise the cost of private health insurance as well through the private health rebate. And then they kick in about 40% of the funding for state government for the public hospitals. And interestingly, in 2019-20, the state and territory governments contributed $34.9 billion to hospital funding, and the Commonwealth government spent $29 billion subsidising MBS items and public hospitals as well. And then non-government entities such as private health insurers spent $4.7 billion on public hospital admissions. So that's public hospital admissions, not private. So what does this all mean? Like, we've got all these people who are involved in funding healthcare in the areas in which we work. And so basically, all of this is underpinned by the National Health Reform Agreement, as agreed at the Commonwealth Heads of Government on National Health in February 2011. And there have been a series of updates since 2011. Most recent is a 2022 to 2025 update where the Commonwealth Heads of Government, COAG, have agreed to change some of the funding instruments. Obviously, over the COVID period, there was increased funding for public hospitals through the federal government as well. But now we're looking at more outcomes-based funding, and we'll talk about that a little bit later, whereby it has been agreed under the National Health Reform Agreement that certain conditions will not be funded relating to complications of hospital admission, whether they're avoidable or sentinel events. There's different funding, the funding changes. So you basically don't get paid the full quantum of funding for a hospital complication such as delirium, sepsis, or if you've got a Staph aureus bacteremia from a line, you get paid no money to cover the cost of that complication. But the basic tenet of the 2011 agreement is that the states manage the public hospitals and the Commonwealth funds aged care, GP and primary care. Obviously, because there is a fairly heavy, it's all politically driven and with agreements between state and federal, part of the NHRA is that they formed HIPAA, the Independent Health Pricing Authority, that has recently changed their name to the Independent Health and Aged Care Pricing Authority, and their function is to derive what a independent standardised cost is every year for hospital care in Australia. And this funding is all distributed through the National Health Funding Body, which is also an independent legislated funding body. So basically, we've got the arbiter sitting there in the background, which is the HIYH. HIPAA was so much easier to say. I don't know. HIPAA. I don't know. So they're basically the arbiter for every year what it costs to operate a hospital or operate admitted and non-admitted care. So HIYH ACPA is basically, their role is to determine a national efficient price for healthcare services, which is how much one unit of activity costs to deliver. They also determine what the efficient cost is for those hospitals that are block funded, and they also develop a specific classification system around what each individual condition costs and will be remunerated at for admission, and I'll talk about that in the next slide. But basically, they sit there and they look at what is the activity, what is the cost, what are the conditions that are currently being treated in Australian hospitals, what is the cost of delivering care to treat each condition, and what's the price of delivering care in a hospital. As I said, they have independent QA and a lot of statistical analysis, robust statistical analysis around how they develop their pricing structures. And ultimately, at the end of the day, every year they publish what they call is a national efficient price, which is how much it costs or how much a unit of activity is remunerated at. And then they also develop a second table, which has got all of the individual conditions that we treat in hospital across infectious diseases, neurology. Everything is in a massive table, and what's called a price weight. So basically, you multiply the price weight for each condition by the national efficient price, and that will give you what the hospital gets remunerated to treat that condition. And I will explain that in a second. But the first point that HIPAA do is every year is they develop a national efficient price, which is based on the average cost of public hospital acute admitted activity for the previous 3 years, with some multiplying factors involved. So this year, the national efficient price, which only came out in March of this year, has been modified to account for a 6% increase for inflation. And they've also modified for the increase in the superannuation rates that hospitals will have to pay their staff. So those are the two main factors that have driven the increase in price this year. And so every year, HIPAA or HIYH now develop and publish what they call is the national efficient price. So last financial year up to the 30th of June, that price is $5,797 per unit of activity. In the next 12 months, it will be $6,032 per unit of activity. And so that's what HIPAA have determined the national efficient price to be. But even though we have the, a national agreement on healthcare funding and how healthcare is going to work and how the money flows, each individual state has then subsequently gone and taken the HIPAA price and modified it according to their own unique locality, modified it for their rurality, modified it for the financial state that they find their state in. So we find that instead of Queensland, instead of paying $5,797, has said that they will pay $5,248 per unit of activity to their hospitals. New South Wales is less. Victoria is even less again. Interestingly, South Australia have determined that they will pay the national efficient price, which is fantastic. Western Australia, heavily funded by iron ore royalties, but also a very large burden of rural and remote hospitals and health service. They pay over the HIPAA price at $6,411. And as far as I can determine, because these figures are not overly transparent, the ACT and the Northern Territory also tag in with the national efficient price. So that's the NEP. So how do we then sit there and say, okay, we've got this national efficient price per unit of activity, but how do I know what each condition that I treat, how do I know how much activity is attached to that? Because everything is not at one. So you can't have a coronary artery bypass graft, which is quite complex and has a length of stay and has a theatre admission and surgeons and anaesthetists and ICU. You can't remunerate that at the same rate as you remunerate an 18-year-old with cellulitis who's otherwise fit, healthy, and well. So what HIPAA do is they publish, but they don't just publish the national efficient price. They also publish the price weight tables, and that's everything during that inpatient and outpatient stay is included in a published price weight table. So, for example, if you come into the emergency department with chest pain and you're category 2 and you're seen within the appropriate time frame, that attracts 0.2 of a weighted activity unit according to the HIYH table. Subsequent to that, you get admitted and you have a coronary artery bypass graft. Now that whole episode of care attracts 6.5 weighted activity units, or 6.5 units of activity. And then you get discharged, and then you go into an outpatient consult, and that consult attracts 0.05 of a weighted activity unit. So going by that, so going on the Queensland efficient price, that emergency visit will be remunerated to the hospital at a rate of $1,049.60. The hospital will receive $34,112 for the admission for the coronary artery bypass graft, and the hospital will receive $262.40 for that cardiology outpatient clinic. So this is this price, so that national efficient price or the state efficient price times the activity gives you a rough guesstimate of what the ABF, activity-based funding, is for that episode of care, which for this is $35,424. So from presenting to the emergency department, having your bypass, and then being seen in outpatients, the hospital will get remunerated that much from the state government. So this is what we call a Tier 1 funding model. So Tier 1 is acute admitted program. And interestingly, if we look at the HIYH ACPA definition of Tier 1 funding, it includes hospital in the home programs, which is very much in keeping with what the Hospital in the Home Society has recently released with their definition of what is hospital in the home. So we're getting things lining up. So HIYH ACPA says that hospital in the home programs are a Tier 1 funded admitted service. And what we do is we calculate how many weighted activity units, how many activity units of the episode of care according to this, what we call the ARDRG diagnosis related group table. Now I've picked 3 very HITH amenable DRGs here. And what we can see, if we have a look at J64B, which is cellulitis, minor complexity, that's what the service that we operate in Townsville. About 50% of patients are J64B, 50% of patients are J64A nowadays. When I first started in 2014, 99% of our patients were J64B. They were all fit, healthy young people with cellulitis. Now, HIYH ACPA says that the average length of stay for a minor complexity cellulitis is about 2.8 days, and a major complexity is 5.3 days. But then what they do is they say there is obviously a statistical range, and this is where all the smart statisticians in HIYH ACPA do their best work, is because they say that they will fund an admission between 1 and 16 days will attract 1.305 weighted activity units. If you come in with cellulitis and it's coded as J64B and you stay between 1 and 9 days, it will attract 0.6624 weighted activity units for that episode of care. If you are beyond 16 days for J64A, then for every day afterwards, they're going to pay this multiplier of that efficient price. So I'll explain that now. So say, for example, if we have a simple cellulitis, J64B, 18-year-old, scratched their leg, has bombed some oral flu clocks, needs some intravenous antibiotics. They've come into your hospital in the home service. They've stayed for 3 days, which is within that in-life. So it's between that 1 and 9 days. So it's how much the hospital gets remunerated for that episode of care will be 0.6624, which is that in-lier, because you're within that 1 to 9 day period, multiplied by, and I'm using the Queensland efficient price here because this is a Queensland table, the hospital will get paid $3,476.27 for that episode of care. Now, there are some riders on this, and in the next slide, I'll show you some of this is not quite this simple. There are some other factors that come into play as to how much, whether you went to ICU or not, or whether you're pediatric, there's a pediatric multiplier on it, where your hospital is. So there's a whole stack of other multipliers on it. But if you just want to make it simple, this is what a hospital gets paid for a J64B simple cellulitis. The big thing from the latest health reform agreement addenda has been that hospital-acquired complications will not be, if you require readmission within 28 days with a complication of that first episode of care, they're obviously not going to pay the full amount for the second admission. So if your J64B patient had their 3-day length of, 3-day length of stay, the hospital gets paid $3,476. But 10 days later, they come back and get readmitted to the hospital, whether it be a HITH service or into the hospital proper. IHACPA says that they will only pay 50% of that funding quantum because they consider that to be a failed discharge. So for that second episode of care, the hospital will not get paid $3,476.27. They'll get paid $1,738.14. So that's that sort of getting into that value-based care and some outcome-based funding that they're not going to pay for complications at the same rate as they will pay and the initial admission. When I was talking about that outlier rate, was if we have a simple cellulitis that has a 12-day length of stay. So remember that our upper and lower trim points were 1 to 9 days. So we're outside that 9-day period. So what the hospital will get paid is they will get paid that first amount, that 6,624 from there, times the efficient price of the state or jurisdiction that you're working in. But then they will pay the outlier per diem rate, which is a per day rate, for every day after that. So that is 0.1 for J64B, 0.1369 times the efficient price again. And that then is 6,350.07. So that's reflecting that our longer length of stay has cost more than you will actually make. It's cost more than 3,476.27. So if we work that price out, and this is where I was talking on the HITH chat when somebody said, how much is a day's admission worth for a particular condition? If you were to work it out, it's $718.45 per day if you stay beyond 9 days for a simple cellulitis. That to me makes no sense because basically if you stay for 8 days, you get 3,476.27, but then after that you get remunerated quite handsomely per day if you stay longer than that outlier trim point. But that does offer you a very simple way of working out roughly what a per day charge is. The other thing to do would be to work out what your length, if you're within that trim point. So say you have cellulitis and your average length of stay is 4 days, then you could work it out that it's within the trim point. The hospital gets paid 3,476.27. So therefore, 3,476.27 divided by 4, you'll make $869 per day if you keep them for 4 days. So just a few different ways that we can use a nationally validated tool to work out what a day of care costs. This is obviously in hospital, but once again, don't forget, this includes hospital in the home program. So this is what your service is generating in revenue. Now there are, as I alluded to, life is not quite that simple. There are a number of modifiers around pediatric adjustment, rural remoteness adjustment, Indigenous, whether the patient received any dialysis during their admission, whether they had any intensive care, whether they were admitted publicly or privately. So, I mean, yes, that is a very complex equation, but if you basically look at it, at the beginning is the price weight, and at the end is the national efficient price. And if we were to say everything else was 1 or 0, you're not going to be far off the mark for a HITH type admission. Step downs would be very different. So tier 2 funding, so that's tier 1 funding. So that is an acute admitted service. Patient is admitted to a ward or a virtual ward on the hospital's patient administration system. The episode is coded at the end of the episode of care, and according to what the coders give, will determine how much the hospital gets remunerated. One thing I didn't mention back here before, and I will break the cardinal rule and go back, is that we have a look at that each of the conditions that we have there's an A and a B rider. There's an A and a B designation. And if we actually have a look, the A and the B attracts a larger quantum of funding for all of the A diagnoses. So normally we find that those A diagnoses are the ones that have major complexity. So, you know, cellulitis minor complexity, 18-year-old with cellulitis, no other medical conditions. Cellulitis major complexity, they've got diabetes, they're a smoker, they've got peripheral vascular disease, they had a multi-drug resistant organism. Those will all change that designation from a B designation to an A designation. So really important. That's why as doctors and as clinicians, all of us here have a duty to document fully what the patient's underlying conditions are, because then that can make a significant difference to our funding designation from just being, you know, if you just write patient has cellulitis admitted to HITH versus patient has cellulitis, here's their past medical history, here's their social history, here's, you know, there's their IV drug user, smoker, peripheral vascular disease, will actually change that designation from B to A, and therefore change how much funding the hospital receives for that episode of care. Tier 2 funding is how we fund our outpatient clinics, how we fund a lot of our community nursing care, and it's all, and according to ACPA, to be included as a Tier 2 funded service, there must be an interaction between one or more healthcare providers, and notice it doesn't say doctor there, with one non-admitted patient, contains therapeutic or clinical content, and has a dated entry in the patient's record. So technically these Tier 2 don't meet the definition of HITH as per the HITH Society of Australasia, but this is how a lot of our traditional OPAT or long-term IV antibiotic therapy has been funded in the hospital system as a Tier 2. You know, these tend to be the longer community-based interventions where the patient's not acutely unwell. So if we look at a Tier 2, and once again, we come back to this national efficient price, state efficient price. So, you know, everything has a weighted activity unit attached to it. So if we look at infectious diseases here, you've got 0.0506 of an activity unit per day or per episode. So once again, 0.0506 times the Queensland efficient price comes up with this $260.55 per visit. And there's also a PBS on this as well, because we're identifying that because the patient's not admitted, the medications can be supplied through the federally funded PBS program. So once again, we have 0.0131 times 5,248, and we end up with $66 for medications. So therefore, you know, $331.55 per day would be what a Tier 2 ID-led OPAT service would be funded or remunerated for per day for that care that they provide. Then we go on to block funding. Now, block funding is just where a hospital gets paid a certain quantum of money every year to open their doors. So when I was the Med Super of Bowen Hospital, we got paid from the state government about $10.5 million a year to run our hospital. It was regardless of how much activity we had. And the reason why was because we didn't generate enough activity to fund the cost of opening the doors of the hospital. Nowadays, back in those days, it was just a fixed price, whereas HIPAA have now, they develop what they call a national efficient cost, which is about $2.5 million. And then you add on a certain, if you have over 175 activity units every year, which would be most hospitals, there is a variable component, but that is funded at higher than the national efficient price. So as I said, for a 30-bed rural hospital, you're looking around about $10.5 million with no procedural services. About $10.5 million per year would be the quantum that you would get, regardless of the complexity of the patients you treat, the number of patients you treat, that's just what you need to pay your nurses, pay your doctors, and pay your allied health, and open the doors. The fourth funding instrument, private hospitals and insurance. Michael and James will attest to this, that this is a bit of a minefield, and as Vonnie and I will also attest to, as full service operators of community-based hospital in the home models, we all have different contracts with different healthcare funds that remunerate hospital in the home at different rates. They also remunerate inpatient care at different rates as well. So this is not just a hospital in the home problem. This is just the challenges of private health insurance in Australia. Some private health insurers will cover hospital in the home, some will not. Some will call it funded at a tier 2 rate, some will fund it at a tier 1 rate. It's quite challenging in this space, and very much harder to actually work out how much you get paid for a unit of activity in the private hospital space. But basically, we have got the most recent data on private hospitals, interestingly, is 2016-17, 657 private hospitals. Some will run a hospital in the home service, most will not, and all geared at providing different levels of healthcare. Hospital cost is covered by the private health insurer and the individual, and as I said, the medical officer attendance is funded through Medicare. So it is that mixed private and federal funding mix. So I'm hoping that has given you a bit of an outline as to the way different hospital-based services are funded in Australia. But I think the next thing that we need to look at is how are HITH services funded? And I think we need to be able to distinguish that there is a difference between how a service is funded to how much revenue it generates. Because most services in hospitals are block funded. So you're not going to have a hospital ward where the ward is funded at any kind of percentage of the activity. Every hospital service, the hospitals receive the activity-based funding. They will then apportion monies down to provide service level care, and most of that is block funded. So they just provide X number of dollars every year to run a medical ward, X number of dollars every year to run a hospital in the home ward. And oftentimes those budgets are based on historically what it's cost to run that ward, plus or minus a creep every year, and that creep is never as high as CPI. It's always 3 or 4%. So what we've got to remember for hospital in the home is, if you look at a medical ward, like that model is as old as time began. We've got 20, 50 years of data as to what it costs to run a hospital ward. We don't have that much. Well, we do in some places, but a lot of places don't have that much historical data on what it costs to run a hospital in the home ward. And I think that's why it's really important for us as HITH clinicians, HITH leaders, people who work in hospital in the home, is that we need to understand what our budget allocation is and what it's actually costing us to build a realistic, sustainable budget and service model. And from that, to understand that we are delivering value-based care. We're all talking about value-based care now, and everyone focuses on value, and everyone says value is money. No, value is not just money. Money is only is a part of value-based care, but we've also got to look at what are the outcomes for the patient. How happy are our clinicians? What is the cost of the service? How much do the patients value the service? So it's not just financial. So we need to be also looking at how we can build a proper budget, how we can build a proper service based on what we know we're being funded, but also based on our outcomes. And I think this probably is the biggest slide, and this is why I've spent so much time, labouring over how the healthcare system in Australia is funded, because it's super important to know how much money our services are generating, whether it be, how much WOW are you generating every year? Townsville Hospital in the home service generates 1,600 WOW per year. And then you can work out how much that is, based on multiplying that by the state-based efficient price. So how much revenue does your service generate every year? Super important to know that. How many patients do you see? Is your service funded as a tier 1 service or a tier 2 service? Therefore, your quantum of funding is going to change. We saw that, if you're funding cellulitis under a tier 2 model, you're looking at $340 a day. If you're funding it under a tier 1 model, it can be up to, $700 or $800 per day, depending on how long they stay. So really important to know how your service is funded. Then understand your data. If we're going to build a business case, you can't just say, I want X, Y, or Z. I want one FTE of doctor. You need to understand, how much money I generate. What's my length of stay? How does my hospital in the home service length of stay and outcomes compare with an equivalent in-hospital stay? That's a really important data point, in my opinion, because then we are comparing. We're getting into that value-based space where we can start to say, we had less delirium, we had less pressure areas, less medication errors. So how does that compare? Our length of stay is less, and I know that from the service that we operate in Townsville, our length of stay for our A designation is a day less than an in-hospital length of stay. Go figure that one out. But it's actually more efficient the more complex the patient is, and the readmission rate at 28 days is less. So it's not like we're admitting them, treating them, discharging them, and then they're bouncing straight back for an in-hospital admission. Where are your referrals coming from? What are your representation and transfer rates? And Michael labours this point, and I completely agree with him, that there's a representation for review, for investigation, is very different to transferring back into hospital care. You've got to tease those two out, because sometimes people need to come back to hospital for things that we can't do in the home, and then they cycle back out to home again to complete their treatment. How satisfied are your patients? Are we doing surveys to see if our patients are happy with the care that we're providing? And the other one is, if we want to go to the quintuple aim, how satisfied are our referring clinicians with the service that we're providing? Are we providing an agile service that meets their needs? And then also, when we're building a business case, you've got to understand the KPIs of your facility. How does your hospital in the home service support decreasing ED transfer times, decreasing surgical bed occupancy so we can improve elective surgery wait lists? How does our hospital in the home service contribute to hospital capacity, and preferably not just surge capacity, but actual hospital capacity? So these are all the things that we need to understand when we're going to build a business case to expand our hospital and the home services, and have a clear idea as to what our service provides and how much revenue it generates, and how much it costs to run. And I'm going to leave it there, because I think I've spoken enough. So I will throw open to the floor.
Thanks, Michael. That's a really nice rundown, and I feel much better when I have to help my kids with their school maths, because that was a lot more complicated. So hopefully you've given us a really nice breakdown of how to go about it, and I'm sure in due course people can go to the references, but also come back to your slides and work through their own processes. I'm actually going to start with the two that Michael Montalto put in the chat there, and are same-day admissions treated the same way, things like chemotherapy or blood transfusions, or are they treated differently? So a number of services now doing lots of same-day admissions. Are they approached in the same way funding-wise, or is
they are?
Yeah, that was a simple answer, wasn't it?
Yep. Yeah. So that in-law, they actually have, if we actually go back to it, there was a same day for cellulitis as well. So for those conditions that have only got a very short length of stay, there is a same day price weight.
And then we've had a question around, obviously patients will come to the hospital, have 3 days on the ward, 3 days in hospital in the home. Do you get half each? How is that approached?
So that's depends on how the hospital works and how the hospital is funded. So that's an internal. The hospital will get paid for that episode of care. So as long as whatever, if it's within that in-lieu length of stay, the hospital will just get paid for the 6 days. It's how the hospital then apportions that money is an internal hospital discussion. So that's an important. I know that when we look at our ABF funding for our HITH service, it includes, so if we've taken somebody who's had a valve replacement done, and we take them for 3 days to finish off their warfarinization, the actual whole weighted activity units for the whole episode of care gets pushed onto the hospital in the home. I know that doesn't actually get funded that way, but you can imagine if you've done coronary artery bypass graft, $35,000, and you've taken the patient for 7 days to treat their stenotomy wound, I don't think you should get the whole $35,000. And that's where I prefer to then look at what's the outlier per DM rate, and then try and calculate your day rate based on that.
Yeah, I think that's a not uncommon strategy, is to go back to a tail DRG rate, outlier rate. Couple of other questions coming through. Thank you for everyone who is submitting those. That's really helpful. Bin Ong from Sydney, we've talked a lot about funding. What about costs? So obviously costs can be measured differently. Is there a gold standard way to measure costs, or how would you go about measuring your costs?
I think measuring costs is just a matter of just doing a proper budget and costing out what your cost of drugs are, consumables, cars, staff. And there is a national efficient cost as per HIYH, but I think in real terms, we've got to identify that different services run differently, have different staffing models. So it would be actually more reasonable to sit down and actually work out what it actually costs. So pull out your Excel spreadsheet and start filling in some boxes, but also looking at things like, a doctor doesn't just cost, 178,000. There's a whole stack of riders that go on top of that. Nursing staff. If we're funding CMs, we've also got to include, what's the out of hours rate, what's the superannuation rate. So actually, if develop a meaningful budget. And then you can develop a meaningful cost base as to what it costs you to run your service.
And I can see Ben put that question in. He's actually popped his hand up there. Ben, do you want to just
Yeah.
Did you need to add some colour to that question?
Yeah, I want to understand more, because sometimes the cost per episode is just given there, and I don't really know how it works out. So because when we actually look at the cost of our unit run, our budget, the cost is actually 3 to 4 times our budget. So it doesn't seem to make sense, and it's trying to work out where the cost coming from, where the other people. So is there a particular formula that is used, that how the cost is derived? And someone was telling me that actually you could have a physiotherapy encounter in one area which actually costs less than the physiotherapy encounter somewhere else though. So when you actually look at how efficient your service, for example, you may have 3 medical encounters in a particular patient, and then the 1 medical encounter another, and then you get the same price for that.
That's right.
Which is more efficient, and are you actually more detailed with your care of a patient, or are you less efficient? So those are the things that we need to grapple with.
Ben, there's nothing in any of those prices per episode of care where it determines, how many medical visits, how many nursing visits, physio. It's all just bundled into the price. And as I said, that's what people get paid. That's what a hospital gets paid to deliver that episode of care.
Right.
Oftentimes we find our hospital in the home services are running at half.
This is hard, yeah.
Yeah, it's hard. It is hard. But
I'm going to come to
only thing. Yep. Sorry.
I'm going to come to Catherine Palmquist's hand in a sec, but just a couple of other really quick ones. With the readmission, where you get the 50% rate, same DRG or any DRG?
Same DRG.
Yep, good. There's a couple of questions there about accessing private insurance for patients in a public hospital.
Most of the public hospitals don't have all of those different contracts that the Cabrinis and the Epworths and the St Vincent's have all got, so they just put it all through as public because they actually don't have those negotiated contracts.
And I think that's the inherent challenge, and having obviously worked in both sectors, that was one of the issues, was to go and negotiate with every possible health fund of every possible patient that might show up on your door is really challenging. Your finance department and others all need to be heavily involved, and you may expend more cost getting it negotiated than you actually attain in funding. But that's the tipping point. If you do enough volume, it's worth having contracts, even if it's the biggest, let's say, half a dozen insurers in your area. Catherine, can I go to you with your hand up there?
Sure, thanks for the talk. Can you hear me okay?
Yep, gotcha. Thank you.
I have a couple of little ones, but the first one was really around that readmission. So it's advocating for us to be extra careful that we're treating something correctly and then giving that advice to try and prevent a future illness. So is it sort of encouraging us to keep people a little bit longer on their antibiotics when we're working so hard to err on the side of antimicrobial stewardship, in particular with cellulitis? It's a difficult one to kind of play because we all know these people who get these recurrent cellulitic lower legs in particular. It's more a comment or a
I mean, it is
thought on
more
that.
of a comment, and I completely agree. I mean, I think all we can do is best practice, and obviously we look at what are our clinical criteria when we're discharging a patient, and if they meet those clinical criteria, then we're always going to have patients who fail treatment.
Yeah, we've started a new program with an elderly and frail cohort who will fall by nature and readmit.
Yeah.
It's not great.
There are different programs that you can put in place that are not necessarily HITH that can help support those patients after discharge as well to keep them in the community. I mean, that's why there's a very large private hospital group in Australia that's expending a significant amount of money on a post-discharge supported program to prevent those 28-day readmissions. And they're getting some good data out of it as well with fairly light touch.
My other thought is just like there must be a sweet spot along here where it's better for us to keep people on our books rather than, like, I don't know, it's difficult for me to understand the non-admitted IV antibiotics versus admitted. So some programs, because it meets our HITH criteria to be admitted for our daily IV infusers, etc. But there are programs doing that, like you mentioned, the non-admitted model. So how would you decide what's financially better? Because assuming you're giving equivalent care in both models.
Yes. It just depends how your hospital's doing it. I mean, under the HITH Society's definition, it should all be funded through and IHIYH CAPA. It should all be funded as tier 1 if it's hospital in the home. Otherwise, then you are going to a tier 2 funded, not admitted program, and the quantum's different. But a lot of OPAT services have run for many, many years under that model.
Because we have a push to pay attention to our length of stays, which the hospital's questioning, and obviously we want to benchmark. But as long as we're in that kind of broad tier, you're still better off having people admitted, because we're thinking about moving cohorts over to our virtual care side just to try and keep our length of stay down. But from the numbers that you've presented,
that's where you've got to have a look at the IPA table, haven't you, and see what's your outlier trim points, because the
hospital's making more money having them admitted.
Correct.
Yeah.
Well, look at it. Like if you look at a J64B, you're looking at about, for a 3-day admission, about $800, over $800 a day. If you do it as a tier 2, you're going to get $341 a day. So there's definitely some smarts that can be done, but also when we're talking about that 50% for readmissions as well, it also says, why wouldn't you put those readmissions on a hospital in the home program if you could? Because we are traditionally cheaper and more efficient than an inpatient cost.
Thanks, Catherine. I'm just going to add there's a couple of comments there. Vonnie Layton has mentioned that there are private organisations you can partner with to get privately insured people out of your hospital and using their services rather than the private providers service. And others have noted that. So Ziad has asked there about the best doctor-patient ratio, and it's probably not directly related to this talk, and perhaps some of the points Catherine has raised and that Ziad here is raising. I'll ask you to comment, Ziad, in just a sec, but I think that might even be the nucleus of a new talk around medical governance, what you do with your length of stay, how long your patient should be on for, what is your role, what is the role of a HITH doctor. Ziad, is that where you were going with that, with the doctor-patient ratio? Because, I mean, from my point of view, it will clearly depend on what it is you're treating and how sick the patients are.
Well, first, thank you for the great talk. It's beautiful. It's probably the best thing that happened to me this week. So thank you.
Thank you.
The other thing is, Catherine, I wouldn't move them. We had pressure. I didn't move them. I stuck my ground. I didn't move them. I kept them. We will get penalised in different ways. That's one of them. Just reduce your length of stay. Where I work, we're running a very tight ship to the point that we've got our acute separations. We have a 5% in New South Wales that every hospital has to refer about 5% of acute separations overnight to HITH. We managed to get that better because it involves the discharge. We managed to get that better by tightening the discharge times, and they got a bit happier and did not push on the virtual one. Now, my last question is to Michael. So let me understand this. So HITH is simply, they're being funded by block funding, despite whatever we make. So it doesn't matter how much revenue we generate. It depends on how the hospital think about what you get. So yes, if I spend 10 days doing warfarin after a cabbage, then they will make 50,000. That doesn't mean I'll get a 50,000. I might only get 1,000. So that's basically it. And that's probably very sad to hear.
But that's the question to ask: how much, how much are we being funded? And that's why knowing the activity that you generate, it's very hard to do that. The step downs are a little more complex. I appreciate that. But knowing how much revenue you generate will then reinforce the business case that you put up when you want to, improve your doctor-patient ratio, improve your, the number of nurses you have on the road. That's the important thing where this talk comes into play, because every ward is block funded. No ward is funded on their ABF.
Yeah.
But we're up against 100 years of knowing what a medical ward costs. And in some of our cases, 5 years of knowing what a hospital in the home ward costs.
So we have an issue in the outpatients. That's our outpatients. We look after 4 hospitals in Western Sydney. So some of our outpatients are physio after having a knee replacement. The NWA goes to the hospital that had
did the joint replacement.
The joint replacement, despite us doing the work. So they spent. Yeah. We worked hard enough to convince them to say, give us the patient on a second day, not when they get up to 180 degrees of movement.
Yeah.
Just give it to us early. We'll work on it to get the outpatients up, and then suddenly they getting the funding. So that's where it annoys.
That's where that outlier per diem rate can give you an idea as to what it would cost per day for that step down care. Because I think the difference is, and Michael's just made this point, that if you have a patient that comes into the ED and comes straight to the hospital in the home ward, you get 100% of that activity. If a patient has come onto a ward, they've had theatre time, they've had some initial rehab in the hospital, and then they're coming to you to finish off their anticoagulation after their valve, their rehab physio in the home, then how you apportion that whole quantum of funding becomes a little harder. And I think the only way that you can reasonably put some transparency around it is to look at that outlier per diem rate, or alternatively work out what it costs you per day to treat a patient.
Thank you, appreciate it.
And that's in a public health service, that's very, very hard. In a private organisation like ours, I know exactly what it costs me on any given day to treat a patient, including a cannula and a dressing.
We're nearly at the end of our time there. Jenna, if you're one really quick question.
Yeah, I just wanted to follow on from that. So we're based at a rural facility, so we're quite limited with, I guess, our HITH hours of service. So often patients might be admitted after hours and they'll go from ED to the ward and then come to us the next day. Does that mean in that situation we wouldn't then get that funding because of that, I guess, incidental overnight stay?
Yeah, it would be allocated. Whereas
usually then it would be straight to us. Yeah, okay.
Yeah, but it's worth asking the question of, and the whole purpose of this is to not just sit back and is to have more knowledge around the funding. have more knowledge around the quantum, how much money's involved, and then be able to go and talk to administrators on, you know, asking those questions. You know,
Yeah.
do we get a portion of the activity? Do we get what percentage of the activity do we get apportioned? You know, and how it goes from there.
Okay, thank you.
All
So
right,
look-
I've just got. Yep, you've got the
Did I
last.
bet you to
You
the
beat me
slide there,
to it. I
Michael?
was going to say I'll go back to my last slide.
Very good. So, firstly, just to thank you, Michael, for the time you've put in, both presenting to us today, but more importantly, the preparation and demystifying some of that. And we hope that everyone's found that useful. If people have found this useful, please give us some feedback. You can either reply in the Teams chat, you can email me directly, president@hithsociety.org.au. Please join the society and support us doing this sort of thing. And also, please come and talk to us at the conference, which is in Adelaide in November. The definition of HITH we're really proud of. We've put it out there. It's been a long gestation to get that to fruition, but we think we've come up with a sensible and reasonable definition that will help you in your discussions with people explaining exactly what hospital in the home is. So with that, I'll leave it there, and thank you, Dr. Michael Young, for your time, and I wish everyone a pleasant day. Bye-bye.
Thank you. Cheers.
Bye.
Thanks, Michael. Oh, James.